tissue acquisition. So, Ulla, मुझे भी शक होना शुरू हो गया है. Sorry. You can hear me, or am I on speaker or no? Okay. So I'll talk a little bit about tissue acquisition. So there are so many needles available in the market, so don't get overwhelmed. Don't get overwhelmed with that. So just get used to certain needles, whatever are available to you. And I think Boston and Cook needles are available here, both.
Boston, Cook, the Olympus, and Kuwait.
Okay, so other thing, before I start my presentation, I just, a few months ago, I gave this presentation for Olympus, so just ignore the slides if it says Olympus on that. So I'm not speaking on behalf of them. So here, just ignore all that, okay. So we are talking about Olympus needle, Cook needle, Boston.
Boston and
Covidian too, okay. And FNA and FNB both? Okay. And what about the Olympus one? Is it the easy shot?
Yes,
It is? Is the new one or the older version?
they one as well, but they have the older ones, both.
Okay.
EUS as well.
So I will come to the needles later as well, like which needle for what site, what type of lesion, and what type of needle. So whatever is available based on that, you can decide what you need to do. So whenever we want to get a tissue, what are we looking for? It has to be cellular. It needs to be enough to make slides. If you're going to do rows, it needs to be enough to make histology slides, to make enough for the core. And ideally, we are not that rich and patients are not that rich. So ideally, if we can utilize only one needle, which we do most of the time, but sometimes two needles may have to be used. And especially for here, the needle is extremely expensive. So what you're looking at, an adequate specimen, which would have which had cellularity, and it's with the obtaining with the use of one needle. So, and you want to minimize the bloodiness of the specimen. So, how can you achieve that? We'll go over that in a little bit. So, FNA or FNB or tissue acquisition, whatever you are performing, it really depends on the area what you are performing. The level of difficulty also depends on that. The easiest FNA is when the scope is straight. And when is the scope straight? When it's in the esophagus, and then in the stomach, and then transduodenal. And so if the scope is in the esophagus, mediastinal lesion is going to be the easiest. Then liver, it's easy to see. Left adrenal, easy to see. Pancreatic body, tail, and head of the pancreas. Submucosal lesion, wherever it is, it's at times it could be difficult because usually those are mobile lesions, and getting a needle into that could be a problematic sometimes. This is the reason. You can see the scope is straight in mediastinum. That's why needle is coming down straight, no problem. When you get to the duodenal bulb, the scope is like this. When you are in the second part of the duodenum, look at the position of the scope. So that makes it difficult, needle coming out and be able to give you the specimen. So A little bit about the definition of samples, cytology, cell block, core. You all probably heard that. Cytology is the individual cells or a small group of cells. And cell block is the one, the specimen, we make the slide and then put the rest of the tissue into the cytolite that is sent to the lab where they centrifuge, make pellets which are embedded in the paraffin, then stained with the H&E, and then that is studied under the microscope. And then there's a term we use, core. Core is like really sufficient retained sufficient tissue with retained architecture or arrangement of cells. That's what is called core. And for certain type of tumors, you may need a core. And also you for now in era or coming era of individualized medicine, you may require core because it needs to do a little more study of that. You need to look at the desmoplastic reaction of the tissue, and that helps you determine the nature of the specimen. So when you do a EUS FNA or FNB, based on what services you have, cytology services you have available, you have to decide what type of specimen you need to get. Certain places, not every place in the United States obviously have an on-site cytopathology, and here mostly is true. Only few institutions will have on-site cytopathology. So that's one is either they are available to come to the room, and here in this unit they have they just make their own slides and then send those to the lab. I don't know, Gaspar, do you have a same setup too? Like you have a cytotech which comes, makes the slides, but you don't have a cytopathologist. Oh, you have it. This is the same way they have trained their people. So. Those your trained people make the slides, but you have a cytopathologist in the hospital at least. So you don't have to send outside the hospital. Okay. So a lot of hospitals, they may have to even send the slides outside the hospital as well. Okay. These are the initial studies. Bottom line is these are mostly studies which were performed basically with the FNA needle. And for those, they have proven that on-site cytopathologist presence helps you get a better quality specimen, helps you decrease the number of indeterminate specimens, and helps you have a better quality specimen and some on-site diagnosis. Okay, so what should be the strategy of tissue acquisition? So if you have a cytologist in the room, if you have available, we will make slides, make a smear, take a look under the microscope. And if you have a cytologist in the hospital, but the cytotech available there, we still make the slides there, make a smear, and send the specimen for cell block. Okay, but if you don't really have a cytopathologist available in the hospital, you have no facility to make the slides. We are coming up to a conclusion that it's better to use a FNB needle, get a core tissue, and then send that in a formalin or cytolite, whatever they desire you to put that specimen in whatever media. When you are getting a core tissue, it's a long thread what you are looking at. Just make sure it's not all red. That could be a clot. So you need to sometimes break it a little bit. Just make sure that there's some tissue, white looking tissue in that. So that would be a real tissue. That would be the real core. Especially if you have to send it outside. So just make sure there's some white tissue into the preservative. So this is, I've talked to those who have listened before, and on this presentation, we have been talking all day, the fanning. What is fanning? Fanning is like you don't want to keep digging or boring into one area with the needle, because the only thing you are going to get is blood out of that. So what you do is you go into one area, then you change the trajectory. You don't want to come out of the lesion, the way you change the trajectory is you bring the needle back to the surface without getting out of the lesion, and then change the direction either with the wheel. You can use the elevator, or you can move the scope in and out a little bit too. So that changes. There are different ways to change the trajectory. Larger lesions is usually harder to fan those. Smaller lesions, it's easier to fan. It may appear it's other way around, but it's not. Smaller lesions are very easy to fan. When you do FNA, you will know that.
Your needle is still in the
That
lesion,
should
but
not come to out of the lesion. Yes, change the direction, bring it to the periphery. If it comes out, that's fine. It's going to happen, okay? But your goal is not to get out of the lesion, and just to change the direction inside the lesion, okay?
If you use the elevator to change
You-
it will be difficult then.
It becomes a little, yeah, it becomes, again, depends on your position, but when you use the elevator, needle goes like this. So it becomes a little difficult. So it's better to use the wheel, if possible, or moving the scope in and out. As a last resort, you can use the elevator too. And I do that. Like either whatever works, I will do that. And it's not that difficult, even the elevator. It's not like it's going to just completely, as long as the needle is out of the scope beyond the elevator, you're not going to have a problem. But the needle may bent in there. Okay, yep. Okay. So suction, earlier people were asking, I think I kind of answered that question. In my practice, it's okay. Okay, it's fine. So you'll still get the tissue. Okay. Sometimes you can straighten it a little bit, but it's hard. Suction. For solid lesions, my goal is always not to use suction. I will try to get, if I don't get a specimen on first pass, I will still make the second pass without suction. If I don't get on that, then I use suction. I mentioned earlier, I use it a different way. I use an intermittent suction. Most people either use a half suction, full suction, whatever works for you. What works for me is what I do is, if I'm using a FNA needle, I'll do 3, 4 back and forth. Then I turn the suction on. I do 3 back and forth. Then I turn the suction off. So I do that total alternate with suction and no suction. But the last pass, I make sure it's without suction because I want tissue, the last amount of tissue coming into the needle without suction, so there's not too much blood in that. Okay, that's how I do it. So suction, no suction, I think either way would work. Then there's other categories explained: wet suction, slow pull technique, stylet, no stylet. I don't use a stylet. It has been proven you really don't need a stylet. The concept behind that stylet was like when you go through the gastric wall or duodenal wall, the tissue is going to get hung up to the tip of the needle. You first need to move the tissue out of the needle and then get that, but it really doesn't make a difference. Okay. Number of passes. If you have a rose, that usually really determines the number of passes, because if you have on-site test evaluation available, then if you see a malignant cells on first pass, you don't need 8 passes or 7 passes. You are done with 2 or 3 passes. You just need some specimen for cell block and you move on. If, however, you don't have that, then we'll talk about you can get the core and take more tissue that way. Previously, on previous studies, when the rose was, then it was just a FNA needle and rose available. Usually it was 5 to 7 passes for pancreatic masses. For lymph nodes, metastatic lesions, usually it's 3, 4 passes. You get a good enough specimen. Metastatic lesions, especially in the liver, they're very, very cellular lesions, so you don't really need many passes on that. Okay. Very safe procedure, excellent safety profile. Complications do happen, especially pancreatitis. Bleeding, less risk happens, but pancreatitis, the way you avoid that, if it's a smaller lesion in the pancreas, and avoid hitting the duct. Pancreatitis happens when you touch the duct, pancreatic duct, with the needle. So that's when pancreatic enzymes are leaked, and that lead to the pancreatitis. Okay, so be careful about that. I would, if I have a choice, I would hit the small vessel, not the duct. Okay, I will avoid the duct at any cost. So here, this is a, you have a question?
What's the apprehension about, why are we so worried about the duct?
Pancreatitis, pancreatic juice leak. Okay.
Why does the pancreas going to happen? Because we are just puncturing, see, we're going to the duct. Maybe this is damage a couple of cells only.
Yeah,
So,
that causes a leak. You run into risk of leak. There's no other way to have a pancreatitis unless you hit the duct. Okay, otherwise you won't get a pancreatitis. And the second, actually, there is another way to get a pancreatitis. If the lesion is way too far away from you and you have a normal tissue of the pancreas in between the tissue and the gastric or duodenal wall.
my
Yes.
question is, in any case, we are going to go through two ducts. Maybe the small.
No. Smaller branch is different. Main duct, that's what I'm talking about. Yeah.
That's the thing that I'm referring to.
Okay.
Is it more of an apprehension or an actual?
No, it's a more risk of every time I have seen like a pancreatitis in my patient, whenever if the fellow is doing not careful, and I really can predict that this patient is going to develop pancreatitis because they hit the duct. And that's like, it's, I haven't published that, but I have seen that. Okay, yeah, clearly I have. And the other thing is like, try not to have too much normal tissue between the lesion and the wall, luminal wall. Okay, so try to find a area where there's least amount of tissue. So it shouldn't be more than 1 centimeter. That's when you can run into a trouble, because you hit the normal pancreatic tissue, you're going to cause a problem there. Okay. This is a lesion, this metastatic lesion. You can see that it's a necrosis. So when you hit the needle in the necrosis, that's what you are going to get. They're not going to be viable cells. This last patient which we did had a lot of necrosis in there. And so if there's a necrosis, no viable cells, what's the purpose of doing that? So you will get that viable cells usually at the periphery. Okay. And this, I think this is a liver lesion. And I mentioned about the liver lesions, they're extremely, extremely cellular. You really don't have to make too many passes out of that. And I like to use a smaller needle for liver lesions. I think I want to avoid the too much pancreatic, too much normal tissue going into the bigger needle. Okay. So why core biopsy? Why core? Why core biopsy? The reason for that is that tumor cells and desmoplastic fibrosis, they both are required for molecular profiling. I talked about the personalized medicine. I talked about the individualized medicine. Now we are moving towards that. And so for that, you really need a core tissue. And if you do a FNA, that's going to be just a cytological aspirate. And for that, you really need to do a FNB needle for histology. And previously, what we were doing when we didn't have a FNB needle, we were using a bigger 19 gauge needle to get some sort of core in there.
Still using 19 kg?
No,
You stopped using.
I only am using for interventions, really. I'm not using 19 gauge needle. For FNA, I don't even remember when was the last time I used it.
Very interesting, you've never used it, 19.
No, I don't honestly even remember when was the last time.
Talking to Asim Yusuf, he says that even for access to the duct as well, he doesn't use 19 gauge, he uses straightforward 22 gauge.
It depends. 22 gauge needle only will take a O2 wire. It would not take yeah. So it depends what type of interventions he is using, how many he doing, what interventions he is doing. So you hardly, or sometimes for pancreatic gastrostomy, for a smaller duct needle, a smaller duct, you need a smaller needle. But usually if I'm going after the bile duct, I'm going to use probably 19 gauge. But if you are doing a transgastric, you probably can use a 22 gauge needle to get into the smaller duct and get a smaller wire through that. So FNB versus FNA, this is really a kind of a too much of a stretch. You can see the this. That's we can get a good amount of tissue with FNA as well. But this is what it's trying to show is like you need a desmoplastic tissue. You need a architect of the tissue to perform molecular studies on those. Okay. So choice of needle, which needle you should use is really based on the location and nature of the lesion. And if transduodenal, as we talked about, we are not using 19 gauge needle really at all, but for that is really difficult to use through the duodenum anyway. So for that, in Europe, mostly it's a 22 gauge needle what they use. And in America, I think still a lot of people, if they don't have access to FNB needle, they still might use 25 gauge. But mostly, I think everybody is kind of moving towards FNB needle. I don't know what your practice is, and pretty much everywhere now we have all the companies except Cook. I think they have a Procore, but that is they call it kind of a core needle. That's what Procore. But I think the other needles they are getting maybe getting some better core tissue. Especially Medtronic needle and Charcot needle, then this Boston acquired needle. So I think we have completely, almost, except me, my colleague Dr. Shaim Verdrajulu, he just uses 22 gauge FNB needle. I sometimes divert from that course based on type of lesion and location of the lesion. If I'm going into the bile duct wall, I only use 25 gauge needle. Yesterday, for the gallbladder, that suspected lesion, we used a 22 gauge, but I like 25 gauge for gallbladder too, to avoid any bile leak. So when there is a risk of bile leak, I go after with the 25 gauge. If it's a liver lesion, metastatic, I go with the 25 gauge needle. And everywhere else, I'm using a 22 gauge FNB needle. Yes?
With the biopsy FNBs, is the risk of pancreatitis more if you were to puncture the pancreas?
So normal pancreas, I would assume is like theoretically yes, because you're going to be hitting the. If there's a lot of normal pancreatic tissue in between, I would not go with the core needle personally. And it's the same thing. I might be just taking a whole side branch out with me and poking a hole there. If there's no normal tissue in between, then go with that. But for normal one, I don't like doing that. Okay.
Anecdotally, I would say that there probably is a bit more pancreatitis. We always used to quote less than 1%, but I have certainly seen that now I say 1 to 2%. I think there is, but if I'm doing biopsies for autoimmune pancreatitis,
When was the last time you did it for autoimmune, and how many you did it in the last 2 years?
no, less than fingers on one hand.
Mm-hmm.
But it'll generally be 25 kilos, 4 biopsies.
Yeah. Even for those 25 gauge, and there's more talking about getting a biopsy of the normal looking pancreas for autoimmune pancreatitis, but I think in reality, in practice, that doesn't happen. Yeah. We try to look for other ways of diagnosis of that. We may do an ampullary biopsy, do a IgG staining on that, and try to depend on EUS criteria for that. Again, the main reason is biopsying a normal pancreas, you're putting yourself in trouble. Yeah. Yep. So this was one of the study we did 22 gauge FNB versus FNA needle. Bottom line was like really the tissue volume was much better with FNB needle as compared to FNA. And again, it's for the same reasons for having a core, more desmoplastic fibrosis in FNB needle as compared to FNA. and also about the diagnostic cell block, much more in FNB as compared to FNA needle. So this is the most one of the recent study we published. We looked at our 4 years of FNAs. You can see more than 3,000 we did in FNA and FNB both. More than 3,000. These are not the EUS procedures. These are the FNA or FNB procedures. 3,000 in 4 years. So between in 2 years, 2014, 2015, mostly it was FNA needle, 22 gauge or 25, and after that, mostly it was 22 gauge FNB needle. If you look at the numbers, almost 69% were FNA specimens, 31% FNB specimens. You can look at the median number for rows. We were doing rows. We still do rows because we have even with the FNB needle, we do a rows on-site evaluation because we have a facility available, and we just want to be sure that we have a specimen on there. And you can look at the median number of passes, 2 versus 1. Diagnostic yield on cell block was much better on FNB as compared to FNA. So if you don't have a cytopathologist available, what we are proposing is really then you should go after with the FNB needle, not the FNA needle. And it usually almost always reliably provides tissue for ancillary testing and molecular profiling. So FNB is different than FNA needle. So FNA, you know that you just have to go in one area 3-4 times, change the trajectory, go 3-4 times in the other area. So it's like a 16 to 20 times you go through in one pass, you go through that mass. FNB is different. I mentioned multiple times, you just go in one area once because you kind of created a tunnel there now, or boring, and as soon as the tissue comes out of that area into the needle, blood seeps in. So if you go back into the same area, you're just going to get blood. So you just change the trajectory right after one pass, and I have shown you that it's 4, I'm going 3 to 4. Sometimes if it's a lot of necrosis there, I may do more. We did more on 5 or 6 on this last case, which was a lot of necrosis, because I know there's going to be so much necrotic cells in there. It's not a FNA needle. That's what I'm trying to really say. It's totally different. And with this one, as soon as I puncture, you see that it's not that like quick movement. I do a slow movement with that. Let the tissue go into the needle. And I don't know what your practice is, but I think for me, it has always generated a good specimen.
Yeah, I've generally done more passes, but I'm going to try this now, to be honest.
What is it?
I usually do more back and forth, but I'll try your...
Yeah, what happens is like, especially with the nothing related to these pancreatic masses, I hope endoscopy is going to take my liver biopsy paper. What I'm trying to propose is the concept I have is like when you do a core once, twice, if you do more than 3 times, you will get the more tissue in there possibly, but you're breaking the fragment which is already in there by putting up more pressure on that. So for liver, it's squeezing it. For liver biopsy, really 2, 3 at the most. Actually, I don't want to go beyond 3, really. I think you do that, that's going to break the tissue by compressing the tissue inside the needle. Okay? So I pretty much talked about that already. Some technical tips. Meta-analysis, when they compared, this is before the FNB needles, okay? When they compared on meta-analysis, when they compared the needles, 25 gauge proved to be better than 22 or 19 gauge needle, especially for cytology. Needle comes with the stylate, so I keep that in for the first pass, but others I do without the passes. Initial FNA, no suction. If limited cellularity, then you can use suction. I use an intermittent suction, as I mentioned before. do the fanning, avoid the central area of a larger mass, and if you have a cytotechnician or cytopathologist, better diagnostic yield. If you don't have that facility available, then get a core biopsy. So, just that. Okay, this is, I said that earlier too. Nobody cares if the needle is in the lesion or not. What matters is if lesion is in the needle or not. Okay, so I think this is pretty much about the next part of this talk is about the intervention. So I don't think we need to go into that. What is it?
I think a couple of things that I wanted to add. The therapeutic needles that we reuse are the 19. The 19 that we use for cyst function are the ones that they go for this gas sterilization.
18.
And then they come back. And so far, they've been okay. I'm pretty sure if you were to properly sterilize them with glutathione or whatever, like you may be able to get away with it as well. But that is an issue. The problem is technical is with the tissue acquisition. The use of the needle. I know most of the Indian colleagues in most of the Indian centers, whether they accept it or not, but off the record at least they've confirmed to me that they reuse.
They are?
They are reused.
Okay.
Even for tissue acquisition.
Even for cancer ones?
Even for tissue acquisition.
Okay.
At